Thank you so much for joining us for this Cholesterol Basics webinar from the FH Foundation featuring Dr. Josh Knowles. We're really thrilled to have you here, and we hope to cover some really great basic information, sort of an introduction to cholesterol. First, I would like to say it's a medical advice disclaimer that this information is for this webinar is for your information. The content is not a substitute for medical advice. Please follow up with your doctor and your medical team if you have further questions and for specific recommendations for yourself and your family. It would be wonderful if you feel that you want to introduce yourself in the chat, say who you are and where you're from. There's the chat function at the bottom of your screen. So please just chime in and choose all panelists and attendees so that everybody can see your post. And it's great to welcome you all here. We're going to use the Q&A for any questions and answers for the questions that you have, and you feel free to enter your questions throughout the webinar, and we will get to them at the very end of the webinar. So use the Q&A for your questions and the chat to say hello, please. The FH Foundation would like to acknowledge our very generous sponsors for the FH Community and Action Program, which this webinar is a part. We thank Amgen, Asperion, Konica, and the families who support the FH Foundation, the FH Family Partners. So for our Cholesterol Basics webinar, we are really thrilled to have Dr. Josh Knowles. He was Assistant Professor of Cardiovascular Medicine at Stanford University, and we are very proud that he is the Chief Research Advisor for the FH Foundation. Welcome, Dr. Knowles. Thanks for being here.
Thank you for having me. It's wonderful to be here. I'm looking at the chat. I'm seeing people from Currituck, North Carolina, I even know where that is, and San Mateo, California, which is right next door to where I live, Canada, South Korea, Grand Rapids, Michigan. So it's fantastic that everybody is joining us. Colombia, I'm not going to be able to monitor all of it, but it's really great that you're all here, and I hope that this is enlightening. I'm only going to speak for about 20 or 25 minutes, and we'll have a lot of time for questions at the end. And I want to thank the FH Foundation for helping me get these great slides together, some of which I'll be using tomorrow when I talk about cholesterol to the medical students from Stanford. So the goals of this webinar are to talk about what causes cardiovascular disease, what is cholesterol and its role in the body, and what to do if your cholesterol is high. So let's start out with, why do we care about cholesterol? Cholesterol is not just a number. Cholesterol can cause cardiovascular disease, and cardiovascular disease, heart disease, and stroke. That's also called atherosclerotic cardiovascular disease. Sometimes we use a lot of acronyms, but atherosclerotic cardiovascular disease, stroke, and heart attack has been the leading cause of death in the US and worldwide for over 100 years, except for a few months during the COVID pandemic. And this is a process that starts early in life, and it proceeds in a very characteristic pattern, but at different rates. Early in our childhood, this is a schematic drawing of what a blood vessel looks like. And this is when we're early in life, we're born, our blood vessels are wide open and clean of plaque. Starting early in life, and that depends some on your genetics and your cholesterol and your lifestyle, we get a little bit of fatty streak. And the little bit of fatty streak is really the first sign of atherosclerosis, and that is cholesterol getting inside the blood vessel wall. And that cholesterol inside the blood vessel wall is not normal. The body reacts to that cholesterol and treats it as an invader and triggers a local inflammatory response. So there is inflammation that occurs in the blood vessel wall due to the cholesterol that's in the plaque that's developing in the vessel wall itself. And over time, that plaque, that atherosclerotic plaque and lesions can get larger and larger, and eventually they can either stop blood flow to the heart, causing chest pain and angina, or they can rupture. Those plaques can rupture, and that's what really leads to a heart attack or stroke. And this is a schematic drawing, but this is what it actually looks like. And here we have an image of a plaque. Sorry, there's no plaque. This is an artery of a child that was killed in a motor vehicle accident tragically, and the blood vessel looks clean as a whistle. And over time, these are actual autopsy specimens from people that died from heart disease. And this is a plaque rupture. This is a heart attack. This is a blood clot that forms in the artery of the heart. And then this is a stain of a plaque, a cross section of an artery. And you can see that the blood is trying to get through this very, very narrow channel. It doesn't have the whole lumen to get through. This is the atherosclerotic plaque that's built up. There's dead cell debris in here. There's inflammatory cells. And over here, you can see these little sharp things over here. Those sharp things in the plaque itself, those are cholesterol crystals. So these cholesterol crystals form in these atherosclerotic plaques, and they can even lead to calcification of the arteries. Calcification of the arteries is kind of one of the end stages of plaque. So why does atherosclerosis development? Well, there's both things that we can modify and things we can't modify. Things that we cannot modify include things like your age and your biological sex, whether you're a woman and postmenopausal, and also your genetics. We can't control who our parents are. We can't control our genetics. We'd like to. I know my kids would like to control who their parents are. And then there's other modifiable risk factors. There's modifiable things like high blood pressure, diabetes, smoking, sedentary behavior. And actually the most important modifiable risk factor is dyslipidemia, high cholesterol. And that's what we're going to talk about today. So what is cholesterol, and what are triglycerides, and what are lipids, and why do these matter? And this is a very simple definition, but it actually tells a lot. Cholesterol is in the body does a few different roles. It forms parts of cell membranes throughout the body. Cholesterol serves as the building blocks for steroid hormones, sex hormones, and other hormones, bile acid binding resins, and oxysterols. It also serves as a modifier of neuronal signaling. Triglycerides are also carried in lipid particles, and triglycerides are a energy source for muscle and adipose tissue. And cholesterol and triglycerides are carried around the body by what's called a lipoprotein particle. And this is a schematic of a lipoprotein particle. Inside is cholesterol esters. This is cholesterol itself and triglycerides. And on the outside is a protein. And that protein allows this cholesterol lipoprotein filled particle to get to the right place and bind to the right tissues and do its job. So this is called the lipoprotein particle overall, and that's what carries cholesterol. What is the dream cholesterol profile? Well, this is what we would like to see when you come to the doctor's office: a total cholesterol less than 200, which means you have an LDL of less than 100 if you've never had a heart attack or stroke. If you've already had a heart attack or stroke, we want your LDL to be even lower, less than 70. We want your HDL, that's the good cholesterol, to be high. HDL high reflects a good and healthy lifestyle. We like the HDL to be high. That indicates that you're exercising and eating a healthy diet. And we want the triglycerides to be less than 100. That would be an ideal cholesterol profile. Let's talk about, where does cholesterol come from? Well, cholesterol, it comes from two different sources. One is from the diet, animal foods and proteins. Animal foods reflect that what we eat is reflected in the bloodstream. About 15 or 20% of our plasma levels of cholesterol, our blood levels of cholesterol, are reflected by the diet that we eat in general. Cholesterol is found in all animal foods: meat, poultry, fish, eggs, and dairy. Plants also have cholesterol, but the human body does not absorb plant cholesterols except for very few rare genetic conditions. So human cholesterol, blood cholesterol levels, is found in animal foods. But our liver also makes cholesterol, and our liver also scrubs cholesterol from the body. It filters cholesterol and lipoproteins from the body. And the blood levels of our cholesterol are 80 to 85% determined by what's happening in the liver. That's important to understand. So for individuals that have genetic forms of high cholesterol, diet is really important, exercise is really important, but we can't change our genetics necessarily. We can't always, we have to do something to combat what's happening in the body naturally. Cholesterol it's actually a fatty, waxy substance. It is produced and found by cells in the body. And I think I've told you all some of these things already. And I'm just going to give you the schematic of what happens. And there's two ways of getting fat and cholesterol. Here we have and this is a schematic pictures of parts of our body. Here's the intestine and the stomach over here. Here's the fat cell, an adipocyte cell, a fat cell here. And here's the bloodstream over here, and here's the liver. So I'm not going to take you through all of these complicated little pictures, but I just want you to understand that when we eat fat and we eat cholesterol, it goes into our gut. It goes from the gut and goes into the bloodstream, and it's packaged into these large lipoprotein particles. They're actually called chylomicrons. They make their way through the bloodstream to the liver. The liver absorbs these chylomicrons and uses that to make other cholesterol, lipoprotein containing particles and triglyceride containing particles. Those go into the body, they circulate around, and the cells take what they need, and they send back to the liver. They send excess LDL cholesterol for recycling. And that's really an important point to know. Excess LDL cholesterol is sent back to the liver for recycling. It binds to a receptor in the liver called the LDL receptor. It is internalized into the liver, and then it is broken down, and then you actually poop it out, excess cholesterol. So it goes into the gut and you get rid of it. So there's a very elegant recycling pathway for cholesterol. And it's important to understand that cholesterol levels in the blood are not just determined by how much the liver produces, but actually they're more determined by how much the liver recycles. And so for instance, in people that have mutations in this LDL receptor, like familial hypercholesterolemia patients, they cannot recycle the unneeded LDL cholesterol, and the LDL cholesterol remains high in the bloodstream. If your cholesterol is high, what can you do about it? And before we talk about that, I would say that it's important to also note that having high cholesterol is a very strong risk factor for heart disease, but it is not a guarantee of heart disease. It is a necessary part of the development of heart disease, but just because you have high cholesterol, it does not guarantee that you will have heart disease. It is not necessarily sufficient by itself. It also takes the other parts of our diet and our lifestyle and our genetics and of the vessel wall itself. But when your cholesterol is astronomically high, it doesn't take much else to trigger atherosclerosis. So that's why people are particularly at risk when the cholesterol is high. And we can talk about that more in the Q&A session. If your cholesterol is high, what can we do about it? Well, diet and lifestyle and management are important. It turns out that the dietary component to avoid for those that have high cholesterol predisposition is saturated fat. So we want to reduce saturated fat. We want to avoid trans fats. We want to eat a diet that's high in soluble fiber. We often refer to dietitians, and exercise is nature's best medicine. We need to be exercising as much as we can. So all of these risk factors help control your cholesterol levels. And to control your risk for heart disease, we don't just manage the cholesterol. We got to take a holistic approach. We need to have a healthy diet. We need to be regularly exercising. We need to maintain a healthy weight, avoiding diabetes, maintaining a good blood pressure, and not smoking. All of these things play a role. If all of these things are not by themselves enough to lower cholesterol levels to an acceptable level and people are still at high risk, well, then we need to turn to medications. And the most commonly used medications are statin medications. There's a lot of, for lack of a better word, fake news about statins. So I just want to tell you a little bit about how they work. They were found in the 70s and 80s. They're originally derived from molds. Their original precursors were derived from these molds that were found. And what they do is when you take a statin, it goes into your liver and it prevents cholesterol from being produced. It inhibits an enzyme in the cholesterol pathway, so it prevents cholesterol from being produced. And so that's one way that it lowers cholesterol. But they're also very important because what they really do is it tricks the liver. The liver says, I'm not making enough cholesterol. I need more cholesterol. I'm going to pull more cholesterol from the bloodstream. So statins really work by decreasing cholesterol production, but also they activate the recycling program. And that's really critical to understand. So what we like to say is familial hypercholesterolemia patients, FH patients, have a problem in their ability to recycle unneeded LDL cholesterol, and statins activate that recycling program. They also do other things. They decrease triglyceride levels. They decrease heart disease death. There are several statins out there, many statins out there. These are all generic now, essentially. We usually advocate for two drugs, atorvastatin, also used to be called Lipitor, or rosuvastatin, which used to be called Crestor, but there's other ones that can be used that are less intense, maybe have a better side effect profile potentially, and those are highlighted here. I'm not going to go over them in depth. We can talk about those in the discussion if they're needed. We know that statins work amazingly well, and I'll talk about how well they work in a second, but statins and other things to lower cholesterol only work if people take them. And if people need statins or they need to have cholesterol lowered and they don't take them, they actually die more frequently. This is an analysis that was done by one of my colleagues, and I was glad to participate in that. But they showed that in the VA system, the Veterans Administration system, they looked at the mortality of people according to how often they took their statin. And the people that took their statin more frequently lived longer, and the people that took their statin less frequently died earlier. And this is a fairly sophisticated analysis, but it's really important to understand that statins, taking the statins if they're needed, saves lives. And we've already been able to quantitate that, and I'm just going to show you this. It looks complicated, but it's not that complicated. These are patients over here. This is a graph of all the effects of some very, very large trials. Randomized trials where one group of patients was given a statin and the other was not, and they were followed for some time. This is patients that already had heart disease. This is patients that did not have heart disease. And each of these names, this group over here is the percent with heart disease event. These have had a heart attack or stroke or died. This is in the group that did not get the statin. This is the same trial, the people that got the statin. This is the group that did not get the statin. This is the same group that got the statin. So in every single case, the group that got the statins lived longer and had less heart attacks. You get a bigger benefit if you've already had a heart attack, but you still get a substantial benefit if you have not had a heart attack. And again, we can talk about that a bit later. There are many now. We're living in a golden age of drug discovery for lipids. For about 20 or 30 years, we didn't have many alternatives, but we now have a lot of things. Again, diet lowers LDL cholesterol by about 10 or 15% if you have a really great diet. Statins can lower it on average about 50%. There's another drug called ezetimibe or Zetia that can lower it effectively, and not quite as effectively as statins. A very old cholesterol medication, Welchol or bile acid binding resins, lower it a little bit. PCSK9 inhibitors, some of you may be on these injectable cholesterol lowering medications. They're very effective. And new on the market in the last few years is another one called bempedoic acid that can lower cholesterol pretty effectively. This is for patients that, overall patients, this is individuals around with many, many different forms of high cholesterol. There are some specific challenges for those that have homozygous familial hypercholesterolemia. These are individuals whose LDL receptors don't work at all. And those folks often need very, very specialized medicines to lower their cholesterol effectively, or even dialysis like treatments called apheresis. So I've said a lot, but I promised you that I'd only talk for about 20 minutes. And with that, I'm going to turn it back over to Kat. Thank you.
Thank you, Dr. Knowles. That was really fantastic. I always learn a lot when I listen to you, and I'm sure that our attendees have also. I wanted to just give a shout out to the FH Foundation. If you find this webinar valuable and the other programming that we offer, please consider making a donation to the FH Foundation. We are a nonprofit research and advocacy organization, and we rely on your support, especially during this cholesterol education month in the lead up to all the activities that month. And I wanted to point out that this is the Cholesterol Basics webinar to give you the introduction. If you'd like more information about cholesterol and inflammation and heart disease, there's I would say, arguably more advanced webinar available on our website, and a webinar on how diet and medication, a lot about diet for cholesterol control. And you can find that on the fhfoundation.org/webinars. Next slide. And we want to thank you all for being here, but also to hold on. If you have questions, we'll answer the Q&A, but we really appreciate everybody joining us for this webinar. And Dr. Knowles, thank you very much for presenting and sharing your knowledge. And we have some really terrific questions here that we will jump into. And please, everybody, go ahead and keep entering your questions in the Q&A, and we will get to them. So one of the things that came through is, and you started with this, I think it might be really helpful to say which comes first, the cholesterol in the arteries or the inflammation? Or could you talk a little bit about that process? Because we hear people asking a lot about the role of inflammation versus the role of LDL cholesterol.
Yeah, and these are inextricably linked to one another. But the way that I explain atherosclerosis, heart disease, to people is that heart disease is really a response to injury. The vessel itself is responding to something that it doesn't like. It responds to injuries caused by smoking. It responds to injuries caused by diabetes. It responds to high blood pressure, which is not good for the arteries. But one of the most important things that causes injury to the blood vessel wall is high cholesterol. And the inflammation does not develop in the blood vessel until there's an injury. And really the first thing that happens is LDL cholesterol gets into the blood vessel wall. It's not supposed to be there, and that triggers an inflammatory response, a local inflammatory response. We know from studies in non-Western societies where cholesterol levels lifelong are very low, that there has to be a certain degree of LDL cholesterol for there to develop atherosclerosis. And let me just give you a few numbers about that. The average LDL cholesterol in the US for an adult is about 130. But that's not a normal cholesterol level for human history. If we go to non-Western societies, people where they're very active and not sedentary, eating a very healthy diet, there are many societies historically and globally where lifelong LDL cholesterols are 50, 60, 70, 80. Babies when they're born, children when they're developing in their earliest phases of their life, their LDL cholesterols are 50, 60, 70, 80. So there's got to be some degree of hypercholesterolemia that really triggers that inflammation, and then that cascades down to lesion development.
So keeping the LDL down over the lifetime is one way to minimize inflammation.
Stop plaque from developing, and even can inhibit, even if you have a little bit of plaque, it can stop it from progressing, for sure.
Okay, thank you. And you talked about the measurements and what that DREAM profile sort of shows you what you might get in a lab report when you get your cholesterol panel tested before or after a doctor's appointment. Could you talk a little bit about, I know a lot of people ask about the LDL HDL ratio, and if your LDL is very high, does that counteract the impact of, if your HDL is high, does it counteract a high LDL? Can you talk a little bit about that?
It's a little bit nuanced, but in general, a high HDL, and by that I mean a reasonable HDL level, 50, 60, 70, 80, 90, something like that, is reflective of a healthy lifestyle. And so a healthy lifestyle, it corresponds with a healthy LDL levels. And certainly a healthy lifestyle can offset some of the badness of high LDL cholesterol. Now, there are people that have astronomically high HDL, like an HDL of like 130 or 140. In that cases, it's not so clear that's protected. There might actually be a problem with the HDL itself when it gets that high. But in general, a high HDL reflects a good diet and good lifestyle, and is good. But we know already that giving people drugs to raise HDL levels doesn't prevent heart disease. And so really, all of our guidelines and all of our management are not centered on the ratio of LDL to HDL. They're centered on how high is the LDL cholesterol and what are the other risk factors that are predisposing people to heart disease. And it's based on those combination of factors that we decide whether we're going to use medications or not. And a level of LDL cholesterol by itself over 190 is very, very high. It's the top 5% of the population, and just by itself, an LDL over 190 is reason enough to use medications. And LDLs below 190 are often reason enough to use medications if there's other risk factors that predispose to heart disease.
Thank you. So it's and that's severe hypercholesterolemia is what they call that, over 190.
Over 190, yeah. One of the questions is, what is the difference between a stroke and a heart attack? A stroke is a decrease in blood flow to the brain that leads to brain cell death, brain cell damage, brain cell death. A heart attack is a blood flow problem to the heart that kills heart muscle cells. And there's different types of heart attacks. One is a full blockage can sometimes be called a STEMI, S-T-E-M-I, and a partial blockage is often called an NSTEMI, N-S-T-M-I, but a stroke is the brain and a heart attack is the heart. Yeah, go ahead.
So I think actually that's a helpful intro to the question of, how can you see the development of atherosclerosis in the arteries? What are the ways that you might be able to see that? For example, the role of a coronary artery calcium scan, a CAC score, and then the follow-on to that is, can you reverse that buildup of plaque? Yeah,
okay, that's good questions. So I told you that atherosclerosis develops in a characteristic way, in a characteristic pattern. And it starts with a little bit of plaque buildup, and over time, if there's been plaque long enough and it's big enough, it becomes calcified. And so we can take advantage of that through what's called a coronary calcium scan, which is a low-dose CT scan that looks at the arteries of the heart and tells us how much calcium is present. Has there been calcium that forms in the arteries of the heart? If calcium is formed in the arteries of the heart, it means you've had plaque there long enough and it's big enough to calcify, and it's kind of a surrogate measure for burden of disease, so we can do CAC scans. It's becoming increasingly common to actually do CT scans where we inject dye and we look in the arteries of the heart. That's called a CT angiogram, CT coronary angiogram, but that's done not routinely. It's done under more special circumstances, and it's getting more and more common, but it's not prime time for people that have never had a heart attack or stroke, certainly. And the other question is, can we reverse the plaque itself? And actually we can. There's no Drano for the arteries. We can't make an artery that's a 70-year-old and diseased look like a 20-year-old, pristine artery. That's the holy grail of cardiology. That's what we're all looking for. But we can, if we get the LDL cholesterol low enough, and by low enough, I generally mean less than 70, maybe even less than 50, we have some evidence that the plaques will start to shrink a little bit, maybe like 1 or 2% per year. So they don't go disappear, but they stop getting bigger. They stop getting vulnerable to, rupture, and they also may start to shrink a little bit.
And the corollary to that would be, how fast do plaques form if your LDL cholesterol is very high and you don't take and you don't lower that with diet and exercise or with treatment?
Say that again.
How long does it take for plaques to develop?
Well, plaques develop over years. It takes years for plaques to develop, and how fast they develop depends on a lot of factors. How high the cholesterol is. Was somebody a smoker? Do they have high lipoprotein A? Do they exercise? Do they have diabetes? But it takes a long time. This is a decades-long process.
So, I know we're not really discussing triglycerides here, but just to touch on it, because the total cholesterol can be very high, and sometimes that can be driven by the triglycerides. Could you just very quickly explain the difference so that if somebody's trying to understand their report, they might understand it better?
Yeah, triglycerides are an energy source. They are carried by the same cholesterol-containing lipoproteins, and certain tissues in your body use triglycerides for energy source. And for a long time, we didn't know whether triglycerides actually caused heart disease or not. There's certainly high triglycerides are associated with things like diabetes and other risk factors, obesity, sedentary behavior. And we now think that triglycerides themselves, high triglycerides, can actually increase the risk of heart disease a little like LDL cholesterol, lipoprotein A, but that's not the major focus of the talk here today. There's other drugs that we can use to lower triglycerides. Statins are quite effective as well.
Okay, so most of what we're talking about here today, just so people are clear, is really principally about the LDL cholesterol. And we do have, I know there are a lot of questions about Lp(a), which is a hot topic. And I'd like to say we have other webinars. We have a Lp(a) basics webinar and an Lp(a) 101. So I think we will focus on some of the other questions here and point you all to those webinars for answers.
A couple of questions are pretty easy though. I mean, LPA,
okay, all right, you go ahead.
LPA is not changed by dietary cholesterol intake. That's one thing. How is LPA related to high cholesterol? Well, LPA particles themselves carry cholesterol around. So if your LPA is really high, you're also going to have high cholesterol and a risk of heart disease. Does Repatha reverse plaque buildup? Yes, anything that we do that lowers LDL a lot can reverse plaque buildup, but only if the LDL gets quite low. So we really think that the reversal of plaque buildup happens when the LDL cholesterol is less than 70. At least that's the evidence that we have. So to reverse plaque, you really need to get your LDL quite low. Let's see, what other questions stand out for you?
Can I ask about, well, let me ask one dietary question, and then I'd love to go into the treatments and their effect on the LDL. You touched on is it dietary cholesterol or is it dietary saturated fat? I think we used to have messages of, it's don't eat high cholesterol foods.
This is a good question. It turns out that the dietary component that should be avoided most when people have a genetic predisposition to high cholesterol is saturated fat. So eating shellfish once in a while, which have high cholesterol levels, doesn't seem to correlate as much with plasma cholesterol levels, with blood cholesterol levels, as do things like saturated fat. Saturated fat is like fried foods, processed foods. Those have a bigger effect, coconut oil, those have a bigger effect on your plasma blood levels of cholesterol than do things like eating an egg once in a while or eating shellfish.
Okay. And does the saturated fat, I've heard that it down regulates, it makes your LDL receptors less active. I find that very motivating.
Well, it's a little bit, that's a very nuanced discussion, and maybe it's a long process to talk about. But I think the most important message is that people that have a genetic predisposition to high cholesterol should avoid saturated fat primarily as the dietary component to avoid.
So then talking about, there are a lot of questions about treatments. One is about the side effects of statins of PCSK9 inhibitors.
Yeah. Okay. So there's a lot about statins. There's no medications that don't have some side effects. There's no free lunches. And the major side effect for statins for people that have high cholesterol or heart disease, the major side effect is decreased heart attack, strokes, and death. But they do cause a small increased risk of diabetes. And I just published a paper about this about 2 days ago. But anyway, very small increased risk of diabetes, mostly in people that are pre-diabetic or overweight or out of shape. And that very small increased risk of diabetes is massively offset by a decreased risk of heart disease. So that's true. Do statins cause dementia? No, they don't cause dementia. In fact, they probably prevent a lot of dementia by causing a lot fewer strokes. Do statins cause liver disease? We have not seen big evidence of that. The evidence of severe liver disease with statins is about 1 in a million. The evidence of severe liver disease without a statin is about 1 in a million. So that concern is quite overblown. The biggest side effect from statins is that in a small number of people, 2 or 5%, they cause muscle aches. And those can be avoided with different statins or different drugs. We can almost always find drugs to lower LDL cholesterol, even in people that can't take statins nowadays, with PCSK9 inhibitors and bempedoic acid and bile acid binding resins and ezetimibe.
Okay. And if you take those treatments, and really we're talking here about people who have high cholesterol and what you need to do to lower it and what the impact might be. So if you lower your LDL with treatment, is there a number that's too low? Don't we need cholesterol in our body?
That's a good question too. Yeah, that's a great question. So And we didn't have evidence for this until pretty recently when we had really powerful drugs like PCSK9 inhibitors. So we know that there are naturally occurring humans out there, that have inherited mutations in certain genes, PCSK9 being one of them, and they have lifelong LDL cholesterols of 10 or 15, lifelong, from the time of birth until they die. And they don't seem to have any problems. They develop normally, they have children, they have jobs, they go to college, they have lifelong LDLs of 10 or 15 or 20, no major issues. So now that's a naturally occurring mutation. We also have pretty decent data now that with drug therapy, it is very, very safe to lower LDL as low as 40 or 50 for a prolonged period of time without any diminution in any major problem that we've been able to identify. So certainly down to a level of 40 or 50 seems to be quite safe. Below that, we don't have a massive amount of data. So that's sort of where we target in some people that are very high risk. The body does need cholesterol. Every cell in the body needs a little bit of cholesterol. But again, we don't need the types of levels that are seen in Western society routinely. The body is quite able to handle LDL cholesterol level in the blood of 40 or 50, and it seems to do well with that.
And can the cells in the body can make their own cholesterol?
Yes, they can. Yep, they can.
So
the way that many of us think about LDL cholesterol is it's mostly a waste product. Most of the LDL cholesterol in the bloodstream is a waste product that needs to be recycled. Certainly over a level of 50, 60, 70, we don't need it, for any biological function that we know.
Okay. So back to the dream cholesterol profile, I think helpful to know, you said above 190 is severe hypercholesterolemia. Some of that population, not all of it, that'll be familial hypercholesterolemia or other genetic drivers of high cholesterol. There's that space in between the 100 and the 90. So I wonder if you could talk about two things. One is, when should somebody really see a specialist? When at what level or under what circumstances do you think somebody might need to look beyond their primary care physician and see a specialist? You're a cardiologist, so of course, a cardiologist like you is somebody we would send somebody to, but does that always have to be a cardiologist?
No, and in many cases, cholesterol is very, very, very effectively managed by primary care physicians, nurse practitioners, endocrinologists, obstetricians. It just takes somebody to think about it and think about the risk that the patient has. I think the most important thing is that specialty referral should depend on risk. Is somebody having very high risk conditions such as FH where their LDLs are over 190? Is this a risk to them or their family members? Is there something that the specialist can offer? Are they having a hard time controlling their cholesterol? Have they gone through, the standard therapies and not been able to do it? Have they had intolerable side effects? Something like that is really, kind of the things to think about. And the comfort level that their physician has or their healthcare provider has. I think those are the things that determine it. Both for adults and children, so there's some questions about children, about when should children take cholesterol medications, and there are a large number of pediatric lipid specialists, cardiologists who are very adept at handling this. We have really great data, not only from the US, but from other countries, that statins are and other lipid lowering therapies nowadays are extraordinarily safe in children. And they do not change sexual development. They do not change puberty. They do not change educational attainment. They basically just prevent the development of heart disease that's affected their family members. So if the cholesterol level is very, very high, you should definitely talk to a pediatric lipid specialist or cardiologist or endocrinologist about that. And statins are very, very safe in kids.
So, and I would like to say, I think one of the messages the FH Foundation is constantly working to get out there is that the American Academy of Pediatrics and the National Heart, Lung, and Blood Institute recommend that all children, regardless of their family history, have their cholesterol checked between the ages of 9 and 11, and again, between 17 and 21 if you have a history of familial hypercholesterolemia or early cardiovascular disease in your family, children should have their cholesterol tested at age 2. And that is in large part to find children with FH. And we've heard many stories where a diagnosis in a child of high cholesterol can change the behavior of the whole family, and for healthier behaviors, but also uncover problems in the parents. And the other plug I'll put in is that the FH Foundation has a specialist map. And so if you do want to see a specialist and you're looking for somebody, you can go to the FH Foundation website and look for a specialist near you by putting in your zip code. And I'm so glad that you talked about the kids, because it's so important.
So let's see, there's a couple questions about diet, and diet is something that, again, it requires a whole hour to talk about, but
Yeah.
And there's a lot of controversy about diet, and certain diets are people feel very passionately about the diets they're on, in terms of how they control their weight or their diabetes risk, and certainly diets that are high in lean proteins and low in simple carbohydrates are useful in some circumstances. But I will say that it's pretty clear that if you have a genetic predisposition to high cholesterol, that diets that are high in saturated fat, like would be expected with a typical ketogenic diet, are going to dramatically increase your LDL cholesterol, and we suspect will increase your long-term heart disease risk. So there are ways of getting ketogenic without eating a lot of saturated fat, without eating 12 pieces of bacon for lunch a day, and those are safer. But it's really important, if you're going to use that kind of diet, to take a close look at what happens to your cholesterol levels, and think about those balancing risks.
All right. Well, I think this has been just incredible, and I know we still have some great questions, and we will do our best to follow up with people. I hope that you got some answers, and similarly, and as I said before, we have these other webinars where we go more in depth on some of these topics, such as diet. This presentation will be available on our website as a recording, so you can watch and you can share it with your friends and family. And we really just thank you, Dr. Knowles, for sharing your knowledge with us, and thank everybody for joining us this evening. And we really hope that you have learned a lot. I know I did. Thank you.
Thank you.